Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health. I'm Joshua Sharfstein, Vice Dean for Public Health Practice and Community Engagement, and a former health commissioner here in Baltimore. Our goal is to bring evidence and experience to illuminate critical public health issues. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hi, I'm Lindsay Smith-Rogers, producer of Public Health on Call. Today, I speak with Dr. Alan Leshner, CEO Emeritus of the American Association for the Advancement of Science. Dr. Leshner is chair of the planning committee for a recent National Academy of Sciences study about the importance of changing methadone regulations to make the life-saving treatment more accessible to those who need it. We talk about why methadone is hampered by stigma and outdated policy, how COVID-19 impacted access, and why this is such an important moment for opioid use disorder treatment programs. Let's listen. Alan Leshner, thank you so much for joining us on Public Health on Call. You are the chair of the planning committee on a report about methadone treatment for opioid use disorder, examining federal regulations and laws. So first, let's talk about what was the background for this report.
So we're actually living in a moment of interesting history, or a moment of opportunity, where for the first time in my adult life, we actually have people both from the criminal justice system and from the public health system feeling this great urgency to do something about the opioid epidemic and the fact that we had 100,000 overdose deaths last year. And we have unprecedented agreement, actually, between these two traditionally disparate approaches or countervailing approaches, criminal justice on the one hand, public health on the other hand. And we have agreement among the Drug Enforcement Administration, the drug czar in the White House, the Office of National Drug Control Policy, SAMHSA, the major drug services agency, and other parts of the Health and Human Services. So there's agreement that we have to do something about it. Overlay on that, a recent report from the National Academies of Sciences, Engineering, and Medicine, actually called Medications for Opioid Use Disorder Saves Lives. And that report laid out the urgency of making access to medications for opioid use disorder much more available.
Let's talk a little bit about why these medications are not available. What are some of the hindrances?
It all starts, of course, with misconceptions about the nature of addiction, the nature of these disorders, and a failure to understand that they really are illnesses, they really are disorders. And then becomes the overlay of stigma that says if you really were a decent person, you just cut that bad stuff out, stop doing it. And of course, all of that's mythical. The definition of addiction is that it's often uncontrollable drug craving, seeking, and use. And therefore, you have a misunderstanding overlay followed by you're really a weak, bad person. And then often people with opioid use disorder do bad things, and that adds the stigma. The other variable that seems to be a major problem is really that historically people saw these disorders as disorders of marginalized people, poor people, people living in ghettos, and therefore they have this stigma of not like us. But of course, addiction is an equal opportunity destroyer and affects people of all types. But there has been I would say, racism overlay over the issue, and that's a part of what has to be addressed.
So how does this actually play out in terms of people who need it gaining access to treatments like methadone?
So methadone, for example, is only legally administered through opioid treatment programs. And historically, they were located in terrible places, difficult to access, and you have to show up every day. If you had a bad urine, if you had a dirty urine once or twice, you got kicked out of the program. And there have been a number of changes over the years that have liberalized that a little bit, but it remains a terrible situation. And only 1 in 10 people who would benefit from methadone actually access it.
So we've got this moment where we have an overdose epidemic. You have agreement among these major decision makers who are creating policy around access to these life-saving treatments. But this is all happening in the context of a pandemic. So how has COVID-19 impacted this?
To start with, COVID, of course, just like any other aspect of the healthcare system, has reduced the willingness, availability, interest, whatever, of people to access the healthcare system, and that includes treatment for opioid use disorder. But on the positive side, during COVID, many of the regulations surrounding methadone treatment were in fact liberalized, and they did not have the effect that everybody was worried would happen. That is, people have kept methadone so heavily regulated because the assumption has been, for example, if you let patients take methadone home, right, in large numbers, well, they'll just inject all of it at once and there'll be all these overdose deaths. Well, the data so far suggests that when during COVID, take-home doses were increased, lo and behold, there was no big increase in overdose deaths. And the message from that is that if you liberalize these policies, bring them into the 21st century, you will not cause all of these terrible problems that people worried about forever.
And the report actually includes some really amazing first-person accounts, these personal stories of patients who are in various stages of recovery. And it really highlights the fact that treatment, especially methadone treatment, isn't one size fits all. So let's talk about some of the policy factors that could be implicated by adopting this kind of mindset.
A part of the mindset, by the way, is this lack of understanding that we're talking about illnesses here. And for almost every chronic illness, there are lots of different treatment options, and some work better for some people and other things work better for other people. So methadone's never going to be a panacea. Other medications for opioid use disorder are not a panacea either. It's just like blood pressure medicine. You know, I take 2 different blood pressure medicines, and when they don't work so well, my doctor switches me to another one. Do the same with medications for opioid issues. I would say that among the first things we want to do is to increase take-homes on a permanent basis. Just say, you meet these minimal criteria, you can take it home. Another possibility is to make it more widely available through pharmacies. If I had my way, we would make it available through physicians' offices. As long as a physician is trained in opioid use disorder, why wouldn't you enable them to treat this illness? And there are lots of other difficult to treat illnesses that we train physicians to treat. So why not do it for this? And that all could be done through a variety of policy changes.
Who needs to be convinced of this at this point? You know, you've got this buy-in from, again, some of these major decision makers. The scientific community, maybe even the clinical community, understands that, you know, we're treating this as a disease. In order for this to actually make a difference in the opioid epidemic, who do we need to convince at this point?
Among the people we need to convince are the rest of the medical establishment, right? There's stigma within the medical fields about opioid use disorder or any other kind of addiction. So that's A. B, we have to train people to understand it. When I said this is a moment in history, don't forget the moment part. It just happened. So there's a long history of misunderstanding and stigma. There are many people in the Congress who still have archaic views. There are many people in the medical professions and other health professions who have archaic views. We got to convince everybody. This is not just about beat up a few legislators and it'll work, or beat up a few policymakers. And as I said before, in my professional lifetime, we've never had such an opportunity as the one that we have now.
There are some really innovative solutions that are happening in this space. Could you talk about some of those?
Well, some of my favorites. I love mobile clinics. I think going to where the patient is so much smarter than making the patient get on 3 buses to get to where you are as a strategy. That's one. Extended release. So a big problem is the criminal justice system. Under 10% of prisons and jails offer any medications, and of them, only 40% offer methadone. So we're talking about an entire system where the majority of inmates are, in fact, people who suffer from opioid use disorders, and they can't get access to the medications they need to treat it. That seems, frankly, stupid. And so we need to go through a variety of ways to increase access through the criminal justice system.
If you could wave a magic wand, what would you like to see over the next 5 years in terms of access to treatment that could really make a significant impact in the overdose crisis?
First, I would like to see a major reform of the methadone system. That is, go through what I suggested, pharmacies and situations like that, doctors' offices, if I had my way. That's A. B, change the way criminal justice system approaches opioid use disorder. Those two by themselves would be a very big deal. Some of the policies that are specific would be to increase take-home doses, to allow it to be administered through mobile clinics on a much more widespread basis. All of these are doable. They can be done. It takes will, it takes political will, and it takes agreement from both sides of the aisle. But I believe that we have it. Many years ago, we introduced the medication buprenorphine into doctors' offices as a way to treat opioid use disorder. There was a hue and cry, are you kidding? Give it to doctors, that's going to get abused very widely. And the fact is it has not been, A. And B, it was passed on a bipartisan basis. It was passed by voice vote that there was support for the concept. I think if we presented a rational national strategy that said, these are the concrete steps we're going to take to address this issue, I think that everybody is so frustrated, and I don't actually care that it's a result of frustration, but people are so frustrated with the current situation that we have a moment of opportunity, not only from the agency leaders that we've been talking about, but from members of Congress on both sides of the aisle. And I hope that in our lifetimes, we'll see this kind of progress occur.
I'm going to throw one more question at you before I ask you for your final thoughts, and that is, who's paying for this?
So the truth is, if you could get patients back to being fully functional members of society, think how much money society would save. In healthcare costs alone, you wouldn't have so many people with hepatitis C who have to be treated, or patients developing tuberculosis on the streets. So that's one part of who will pay, is the healthcare system. Secondly, you'll reduce criminal justice costs. Okay, that's a big expense. Now, I'm not a fool. I know that you don't move money from one sector into another. But if you're looking at the issue as a societal issue, you should be able to do all that balancing. And there's no question, treating people is always cost effective, because if you don't treat them, you have to pay for all the other bad things that either will happen to them or that they'll do.
And now I'll just ask you for any final thoughts you have about this report or about this moment.
So I will say I was really delighted to see how the speakers at this particular workshop all accepted the challenge we gave them. This was the most fabulous planning committee, by the way. And what we decided was we didn't want to have just another glossy conversation. What we wanted was to tell people, you can get up, you can talk. We don't care whether you want to talk about the things that are bad. But what we really want is for you to tell us what needs to be done. And that's what's in this report. And I think it's the beginning. It is not a blueprint. There isn't enough in it. And it's not a consensus report from the academies. But it sure goes a long way to laying out the opportunities and the kinds of steps that could make a big difference.
Alan Leshner, thank you so much for joining us.
Public Health on Call is produced by Joshua Sharfstein, Lindsay Smith-Rogers, and Stephanie Desmond. Audio production by J.B. Arbogast, Holly Cardinell, Spencer Greer, and Matthew Martin, with support from Chip Hickey. Distribution by Nick Moran. Production support from Catherine Ricardo. Social media run by Grace Holes Fernandez and Amber Bryan Singletary. Thank you for listening.